Good afternoon and welcome. This virtual webinar is a collaboration with the U.S. Department of Veteran Affairs, VA Center for Faith and Opportunity Initiative, and the Veterans Health Administration Office of Mental Health and Suicide Prevention at the Durham VA Medical Center. My name is Trulesta Pauling. I am Senior Outreach Specialist in CFOI. I will be your moderator this afternoon. Thank you all for joining us. Right now, everyone's phone will be muted by CFOI. If you have a question, please type it in the Q&A box on the right side of your screen. I will read the questions at the end of the presentation, and Ms. Chavis will have an opportunity to respond. First of all, I would like to thank Ms. Tiffany Chavis and her office, along with Chaplain Wallace Allen, for this collaboration. We are grateful for your partnership and for providing this training. Next, I would like to introduce Mr. Conrad Washington, the Acting Director of the VA Center for Faith and Opportunity Initiative. Mr. Washington is a retired combat Marine and served on active duty for 20 years. He's been with the VA since 2013. He is a licensed minister and a man of faith. Now I'll give you Mr. Conrad Washington.
Thanks, True. I appreciate it. So thank all of you for joining us today. I see we have about 46 people on the call. I thank you all for taking time out of your schedule. I specifically want to thank Tiffany and Chaplain Allen for hosting this and bringing your expertise to the table, because this is a very sensitive topic. I understand that, but it's also a very important topic, as we all know, as people of faith. And it's my belief that as we attack this health issue, that is bigger than just the VA, bigger than just veterans. So we're reaching out across the nation to get everyone to work together, right? And so a couple of things about the Center of Faith. We're here, and I want to thank my team for putting this on and doing all the great work they're doing. We're here to reach out to faith-based and community organizations across the nation on topics just like this: suicide prevention, VA homelessness, and so forth. So if you want to reach out to us to host a webinar, at the end you'll have some point of contacts for you so that we can collaborate and partner with you so that we can reach more veterans. And so with all that being said, I won't hold up the show here. We'll keep it going. And thank you all very much for attending. If you have questions at the end, Ms. True will read those questions to Tiffany, and we'll get your questions answered. And we also have some information for you as well if you have not had an opportunity to download those information prior to the event. So thank you all for joining us, and I hope this is very beneficial to you. Be blessed.
Thank you, Mr. Washington. Now I would like to introduce Ms. Tiffany Chavis. Ms. Chavis has been in her current position as a suicide prevention coordinator since 2019. Ms. Chavis received her bachelor's degree from North Carolina Central University and received her master's degree in social work from North Carolina A&T State University. Ms. Chavis has worked with different populations, including children in foster homes, families in public housing, and recently homeless veterans and those at risk for suicide, and harbor a particular interest in overall wellness and resilience of veterans and building community partnerships, especially within the faith community. Ms. Chavis has one son, Theodore, who is 15 and enjoys sports, football, traveling, and shopping. Now I would like to introduce you to Ms. Tiffany Chavis. Tiffany, the floor is yours.
All right. Are y'all there? I guess you missed the part. So thank you for this opportunity. Thank you for Ms. True for the introduction. Thank you, Mr. Washington, for initiating and coordinating. And in advance and barring no technical delays, thank you for Mr. Morales for your technical support as well. Before we begin, In the description you see about me, yes, that is true. I do spoil children, but I also commit to their lives. And so full disclosure, I try my best to live by example. Also, full disclosure, I am not a veteran. I have no direct military experience. However, I have learned from my veteran colleagues, my loved ones, and I severely defer to their expertise on military culture. The third thing of disclosure before we get started, typically these sessions are done in person, and that will allow us to kind of judge myself and the co-facilitators to judge the crowd and assess should there be any points in which participants may become triggered by the subject matter. We will take a brief overview and will not go as in-depth as we would have in person. But since I'm not able to do that virtually, if you, if for some reason at any point in the presentation become triggered, please send a message on the side in the chat box to the panelists. If you'll click down where it says all participants, under that you should have an option to message all the panelists instead. And we will reach out to you individually during the session. After the session, after the webinar, please, and I can't emphasize this enough, please feel free to reach out to me directly. If I can't connect you with whatever you're looking for, then I will make sure that I connect you with someone who is able to support you. The information in this presentation is primarily drawn from the VA's National Strategy for Preventing Suicide, and it is attached to your handouts in this webinar. You will be able to refer to that later on for your information. So let's jump right in. As partners of faith in suicide prevention, we want to provide some connection between what the VA does and what the partners of faith, kind of their overall missions and goals. So today, here's an example of what we're going to discuss. And I'm sure that each of you can ascertain and read further, so I will not belabor the overview and the agenda. So as suicide prevention coordinator, one of the things that we focus on, or two of the things that we focus on, are community collaboration and suicide prevention education. Most recently, we've added to our team a suicide prevention peer support specialist who is really instrumental in helping to kind of coordinate each of these activities. So when we say outreach activities and events, we're talking about anything from walking around a shopping mall and handing out flyers to hosting events ourselves in which community members and partners can come together and spread awareness about suicide prevention, but also about mental health and overall wellness. I mentioned the Mayor's Challenge because most recently Greenville has been in discussion with the Mayor's Challenge about becoming a pilot site. And so what that will do is enable community partners to slide a little closer to the table and to work on one agenda when we're talking about addressing and reducing veteran suicides. The suicide education prevention component is part of what we're doing here today. And so offering and sponsoring virtual SAVE trainings, and we'll talk a little bit more about what SAVE is, connecting veterans and community partners with the Veterans Crisis Line, providing some support to clinicians, whether they be inside the VA or in the community, around safety planning for veterans, around clinical consultation, around assessing suicidal behaviors, those sorts of things that also fall under suicide prevention education, and that's part of what my responsibility is. And also, I listed employment there because as we go further along in the presentation, you'll understand how employment and community connection are extremely important in the lives of veterans. And so we've worked really closely with some employers as they began to recruit veterans primarily. And so those are some of the things that are coming about and presenting wellness and mental health awareness sessions to employers in the community as well. So the statistics. These are general population statistics around suicide in the U.S. And as you can see, it's the 10th leading cause of death. So, we're thinking about what causes someone to complete suicide. And there's no single cause of suicide. Risk factors make someone more likely, more at a greater risk of suicide, including mental health diagnoses, life stressors, a previous suicide attempt. However, we also should spend some time talking about protective factors, which can offset those risks. And so we'll spend a few minutes later on talking about social determinants of health and how partnering with the faith community can help someone grow their social determinants of health, and also promote a sense of life purpose and feeling connected to others. So I bring this slide up because this image is really important. If you'll notice, women attempt suicide 3 times more often than men. So those are the attempts. However, men die by suicide 4 times more often than women. And so I know that it's, we can kind of deduce what those numbers, how those numbers are attributed, but 40% of women who complete suicide do so by use of firearms. 67% of men who complete suicide do so by firearms. There's also a large portion, 32% of women who die by poisoning or overdose, and 10% of men who die by poisoning or overdose. And so this slide says to me that we should spend a lot more time reducing accessibility to firearms, using that as a key strategy to reducing death by suicide. One of the things that the VA also does really well is we offer and partner with community providers to give gun locks. We give free gun locks to anyone who's interested, and we'll talk more about that as we talk about how to help someone who may be considering suicide. So here again, we're looking at kind of general statistics. Why are we focusing on veterans? A lot of people ask me, what is the difference between veterans completing suicide and adults completing suicide of the general population? Well, as you can see, 18% of all deaths by suicide among U.S. adults are veterans. The reason that we're focusing more our efforts on veterans is because veterans only make up 7% of the adult population. So 7% of the general adult population in the U.S., however, 18% of the deaths by suicide. That says to me that we should spend a lot more time on veterans, not to ignore the general population, but veterans are trained in firearms. Veterans are maybe more comfortable with firearms, and veterans typically have more external issues that may impact their ability to cope. And so, we're talking about reducing those risks. We're talking about helping them build stronger communities. We're talking about helping them reduce their risk factors. And 25% of veterans who died by suicide had a previous attempt. As I mentioned that earlier, those are direct risk factors to a suicide completion. And so the VA has adopted a public health approach to preventing suicide. It's using the public health model that the Center for Disease Control and Prevention has utilized. And so the first step is defining the problem. So based on the previous slides, I think that we have defined the problem with 18% of all deaths of U.S. adults being by suicide or veterans, but only 7% of the population making up veterans. I think that the problem, we can all agree, is veteran suicide. So identifying the risk and protective factors is the second point of the CDC's approach. Developing tests and preventive strategies is the third, and then a widespread adoption among stakeholders, other healthcare providers, churches, employers. That's the other step that will help with the public health approach, because we want everyone to be aware of how they can help with suicide prevention. So this slide, I call it the 1/3 slide. So on average, 20 veterans a day will die by suicide. And 1/3 of those veterans who die are enrolled in VA care. So if you're looking at this graph, the folks in blue are the veterans who died by suicide. that were not enrolled in VA care. So, I think it's fair to deduce that being enrolled in VA care can be a protective factor. But also, as the VA, I think that we have to become okay knowing that some veterans may never come to the VA. Some veterans are not going to enroll in care. Some veterans are not going to reach out to the VA. But are we okay with 1/3 of our job being done? If you went to a restaurant, would you be okay with 1/3 of your meal being served? And I think that answer is going to be no, and that's why we need our partners. So that's why we're going to rely on non-VA healthcare providers, veterans organizations, law enforcement, employers, and especially, in North Carolina and the South, we're going to rely heavily on our faith partners. Historically, this region has had really close ties and affiliation with religious organizations. And, if veterans aren't coming to the VA, they're going somewhere for their support. Most likely it's going to be a spiritual support. And so we want to make sure that we equip our faith leaders and faith organizations with ways to assist veterans. All right. So this slide just kind of gives you some numbers, additional numbers. You see the estimated veteran population at 19.6 million, and the VA having served and registered 6.3 million. So there's a huge gap in those veterans who are eligible for VA care with those veterans who are actually receiving VA care. So we need the community's help and support in getting to those veterans who are eligible but not yet receiving VA care. So I'm part of the public health approach. We're including the widespread approach and widespread education. So the VA has come up with, the Office of Mental Health and Suicide Prevention has developed a training module that can be utilized in any type of facet to promote suicide prevention, education, and awareness. And it's called SAVE. And the acronym SAVE stands for looking for the signs, asking the most important question, validating veterans' experience, and encouraging and expediting care. Suicide prevention is everyone's business. It should be everyone's investment. And a lot of times I think that we don't understand how we can help or how we can prevent suicide. And so the SAVE acronym really gives us some key pointers into doing that. And so with the first aspect, with looking for signs or acknowledging signs of suicide, if you're in a relationship with someone and you know someone really well and you notice that they're talking more about wanting to die, they're talking about feeling empty, feeling hopeless. They may be referring to themselves as being a burden to their family or to their friends. They may be making a plan, either stockpiling medications or ammunition or talking more about their guns and weapons that they may have access to. You also may notice as a sign of suicide an increased use of drugs, alcohol, or risky behavior. So if you have a friend or loved one or colleague who typically goes strictly by their budget, never spends more than, their allotted budget for their week, and you notice that they're making extravagant purchases and, with sort of no regard, that could typically be a sign of suicide or suicide contemplation. Also, withdrawing from friends, giving away important possessions, and giving away important possessions is different than sort of life planning. So if someone is talking about their insurance policies and what they would do if their life ended, that may be different than giving away their military awards and honors, or acknowledging that their time is coming to an end quickly. So these are all signs of suicide. You don't necessarily they don't necessarily come up as obvious a lot, and so because of that, you want to ask the most important question of all, which is, are you thinking of killing yourself? And the reason that it's important to be that direct is because you want a direct answer from your loved one or your friend. you want to hear from them if they are considering suicide. I would strongly encourage folks to not present the question as if there may be some implied judgment. So not saying, hey, you aren't thinking about killing yourself, are you? Because when it's asked that way, the impression is that you want to maintain or that there's some guilt around having thoughts of suicide. And I would even offer that 80% of all adults have at some point in their life considered suicide. And so normalizing the thoughts of suicide are what we want to spend time on, and helping someone understand that there is no judgment passed from you by asking that question. So we want to be clear in saying, are you thinking of hurting yourself? Are you thinking of killing yourself? Have you thought about suicide, and preparing for a direct response? Then the next aspect of SAVE is to validate the veteran's experience. And I can't say how important this is. It's not necessarily that we need to give a soliloquy about why it's important for them to stay alive, or why it's important for them, to live for their family or for the job or for the community. Simply saying, I understand. Thank you for sharing with me. Thank you for trusting me with that information. I want to help you. How can I support you? Is more than you can offer, more than you can imagine offering someone who is really contemplating ending their life. If someone comes to you and they feel comfortable enough to share with you that suicide is an option, they're not necessarily looking for you to solve everything right then, but they are looking for you to have some compassion and show some understanding with what they're going through. And so the last component of SAVE is to encourage treatment. Encourage treatment, and sometimes you may have to expedite getting help. And so let's compare that to, if you saw someone and you noticed that they were bleeding, okay, well, clearly they need a bandage. And if you have any kind of medical experience, then you're going to offer them a little more than that. And so in encouraging them to get treatment and expediting help, you're not necessarily saying that you are a licensed clinical social worker or other licensed practitioner. You're just saying, listen, I know you need help, and I want to help you get there. And so that may look like making the call to the Veterans Crisis Line with them in their presence and have them on the phone. It may also look like volunteering to go with them to their first mental health appointment. That's a huge step in treatment, and it's also can be daunting if someone has never been to the VA, they've never considered themselves to be depressed or suicidal, and they've never been in a formal traditional treatment relationship. So offering to be that supportive hand and to help them to get oriented into treatment could be a huge help for someone who's considering suicide. I'm looking for questions in the comment, and I don't see any, so I'm going to move on. So while this is kind of a triage, we don't expect for anyone to do on-scene or on-site therapy. It is important, though, that in having this conversation, you recognize that there could be some safety factors. And so, we're not advocating to have this conversation if someone is holding a weapon in their hand. That is definitely time to bypass each of the SAVE aspects and go directly to calling 911. But looking for the signs, asking the questions, validating the veteran's experience, and encouraging and expediting care is how we can partner better. So if you just help to notice a problem and getting them to the resources that they'll need can be a huge, huge asset to someone who may be considering suicide. So in getting someone connected, we've listed the Veterans Crisis Line, the 800 number, the text feature, the Connect Online. Any of those are available. And these are available 24/7. And so if you feel like someone can benefit from talking to someone immediately, then definitely reach out. The other thing about reaching out to the crisis line is that the crisis line is able to then connect the veteran with a local provider. And so on our end at the Durham VA, we'll receive each of those referrals, and we can follow back up with the veteran to say, hey, I noticed that you called. Thank you for calling over the weekend. can I help set you up a mental health appointment? And that can be the bridge that can make a difference in a veteran's life. Now, so we've talked about kind of the numbers, suicide prevention, what suicide prevention does, but that's sort of the VA's in the VA bucket of it all. And what we've spent time doing is embellishing or helping to grow the VA bucket, but also realizing that we can't do this work by ourselves. It doesn't happen in a bubble, which is why we rely heavily on our faith partners. Partners of faith contribute directly to the social determinants of health. And so we're talking about social determinants of health. We're talking about conditions in the places where people live, learn, work, play, and worship that affect and build a wide range of health and quality of life outcomes. And so on this table, I think if you consider yourself in the middle of that circle, if you think about your economic stability, well, where does that come from? So for a lot of people, that comes from employment. It may come from some type of benefit. But if you think about your economic stability, you have a direct correlation to how that impacts you. Also, neighborhood and physical environment. We want to feel safe. You know, you may have an alarm on your home. You may have locks on your doors, but you also want to walk outside and know that you aren't threatened by doing so. With the healthcare system, you know, most of us have some type of insurance or either access to some insurance. And so it doesn't have to look like the VA. It doesn't have to be the formal big VA. It can be a community provider. It can be a community clinic. But knowing that you have somewhere to go if you don't feel well is important as part of your social determinants of health. Food and education for obvious reasons. You want to feel as though you have access to quality education. You want to feel as though you have access to food and healthy food options. But the one thing that the VA doesn't necessarily have its grasp on or its teeth in are the community and social context. So this may look like, in some cases, a peer support specialist and going into the community. I know our peer support specialist is forming a garden club and interested in doing some recreational things that will help get veterans engaged. But also a part of veterans community is the faith community. And the faith community is important because it can connect each of the other social determinants of health. You know, when I think about my experience in the faith community and how I was engaged in my home church, it was a part of the neighborhood. We had access to education. If someone needed assistance, there was some support to provide some economic stability. And so the church is often involved in each of the aspects of social determinants of health. Now, this is a very busy slide, and I don't want people to read all of it because it will truly bore you, but I do want people to look at the solution of it all. So the solution is that VA has partnered with faith-based organizations in veterans-owned communities that will give us more boots on the ground. And so by doing so, we want to help faith leaders learn to recognize the signs of a mental health problem, feel more comfortable about talking about depression, learn about and understand the importance of gun safety, and widely distribute free gun locks to veterans. And the VA has that as a resource, and that's why we want to connect with our partners so that we can distribute that. So part of the strategy is training those high-risk, high-need communities in suicide prevention. So building local teams within the VA and with our community partners to hold training events such as these, but that prioritize veterans in high risk and connect them with their faith-based organizations. We're also asking faith-based organizations to be represented at the VA. So we're talking about joining or beginning community coalitions. We need our faith-based partners there at the table so they can address and help us understand how to better connect with veterans who are engaged in faith-based organizations. So one example that I want to discuss is the partnership with the Center for Faith. So the VA in January held a half-day event in Greenville for faith-based leaders. We partnered with local churches. Close to 40 faith leaders were in attendance. And during that time, we spent time talking about what the church is doing or how the church can help in mental health awareness, overall wellness, and suicide prevention. We completed a SAVE training and allowed for question and answer and role playing to get more comfortable with asking the question, are you thinking of killing yourself? There was a second portion scheduled, but we needed to cancel it due to the pandemic, but also bringing VA programs to the local community. And so there were presenters scheduled for VA benefits, caregiver support, women's veterans, but also local community partners who were there to provide overall community information. And so the goal is to help build and help connect faith partners with the VA. So one reason or one thing about including specifically faith partners is that faith groups have a strong reverence for life. It may look different. They may operate under different doctrines. Their methodology, their populations may be different, but most of them encourage a connection to a purpose in life. And a lot of times when someone is considering suicide, they may have lost that connection. Opinions and beliefs about suicide may differ among specific faith groups, but they all affirm, though, that suicide is painful and that the thoughts and behaviors can be eliminated by guiding them back to that purpose in life, that shared purpose in life. And so one of the things, as we mentioned earlier, is connecting clergy, training clergy on the signs and symptoms of mental illness, and collaborating with mental health providers through the VA, but also in the community that can serve as a conduit to veterans getting in mental health care. As mentioned earlier, most suicides can be prevented. And so in going back to the social determinants of health, connection and overall wellness is going to be huge in reducing the number of suicides. If you'll notice, the stigma and culturally acceptable language and lack of culturally appropriate mental health services, I like to call this the pray about it and then what. And so for us, for mental health professionals, it's not saying that just faith isn't enough, but it is saying that faith and training, faith and knowledge of mental health and mental health services can help reduce or minimize the risk of suicide. And so we want to provide equipment to our clergy so they understand how to deal with the parishioners when they come to them for training that is, for support around suicide and around mental illness. So this slide, you'll see many different ways to partner, many different ways to collaborate. Hosting a family day, most churches have their own locations, and so it's typically a good place for everyone to come together and spend time around some healthy sort of overall health and wellness events. Churches and faith organizations can also host a SAVE training. And so I've gone to Sunday services, also open to attending a Bible study or a prayer group, whatever the church is sponsoring, so that I can connect with the population and give information out. Chaplain Allen is going to speak to us next about support for postvention. So what happens, how do you get support after a suicide happens? And so he'll spend some time with us on that, but also providing information in church bulletins, websites. We can work with churches to provide a web link, or if they have mail outs, just give information about suicide prevention and ways that we can partner. So these are just a few that we've done, and they'll be for your reference for you to look through and consider later on. Now I'm going to turn it over to Chaplain Alice Wallace Allen. Oh my goodness, tongue-tied, tongue-twisted. Chaplain Allen is a chaplain with the Durham VA, and he also covers the Greenville and Morehead City area. And Chaplain Allen does a lot of work around moral injury and postvention. So, Chaplain Allen, I'll hand it over to you.
All right. Good afternoon, everyone, and thank you, Tiffany. So first of all, I'd like to say that as a VA chaplain, one of my major roles, or as VA chaplains, all VA chaplains are an integral part of the interdisciplinary treatment team for our veterans. And so I just want to briefly go into what I'm seeing with moral injury, and there is a rise for veterans that's been diagnosed with PTSD to also come in with moral injury. So what I'd like to do for a few moments is briefly talk about what moral injury is. And what I'm finding is that when working with treatment teams or mental health providers, I often share this stop, look, and listen model, and along with a community clergy also. First of all, moral injury it's a betrayal of a person's moral compass by a legitimate authority figure in a high-stakes situation. And this was presented around the late 90s into 2006 by Dr. Jonathan Shea, who is a VA psychiatrist, and he was working in the Boston area. So what he saw was a trend for veterans coming back from Vietnam, and the three overarching behavior patterns were self-harming. People didn't feel lovable about themselves. They didn't feel like they could love themselves, or they didn't see love in the world. Self-handicapping, again, which goes back to self-sabotaging. Anytime they felt like they were getting, things were getting too good in their life, they feel like they should do something to kind of throw a wrench in it or mess it up. Let's just say common terms, mess up marriages or jobs that were doing too good. And then he noticed that the demoralization part on the terms of veterans who had seen too much evil in the world or tragedy, and they couldn't see any good in life. And if you ever saw John Rambo, the movie Rambo was a good example of all those three overarching behavioral characteristics. So then when we move to what we're looking for, pretty much is that as PTSD, moral injury and PTSD, the signs and symptoms marry pretty much, with the exception of the acronym SARG, which is sorrow. Moral injury presents or shows up in people having that overarching or sorrow, very sorrowful, deep sorrowful confessional language. If you listen to people, the veterans or trauma survivors, they may have a sense of withdrawal or alienation, can't really be comfortable connecting with people. There's a sense of regret. And I hear this a lot. They say what I should have did, or what if I had to do what I had to do. Then another part of what the acronym SARG is guilt, and this guilt could be a survival guilt, or the guilt of saying, why didn't it happen to me? I was there, or somebody took my duty and they got harmed. And then another piece of this shame, which can show up in blaming the institution, blaming God, blaming others. And this shame is kind of like one of those things that people go into hiding. And so then what can we do, or how can a community clergy person tell? And I want to just briefly talk about one of the stories of our veterans that I got assigned to provide pastoral care for. He was a 3-time Vietnam veteran. He was diagnosed with PTSD, and he had attempted suicide several times. And one of the reasons why he was coming to our clinic, was the mental health clinic, was because he was yelling at his daughter, his 5-year-old granddaughter. And he didn't like that. He wanted to change his behavior, and he was feeling hopeless. And so as I listened to his story, I could hear a lot of anger in his story. And I could hear this sense of longing for hope and meaning in life. And so as I started working with this veteran, again, I could hear this deep anger at God and this deep pain. It was like his soul was crying out. And he told me, Chaplain, you only got one shot to get this right. So I just let him talk. And as I let him talk, I heard this anger and this bitterness, and I listened to him, and I'm encouraging us to listen to the veterans that come in front of you without judging them or trying to give us a quick answer or a quick fix, because that's not going to work in some cases. They just basically want to be heard because their soul is hurting so bad. There's a sense of mourning. And so if we can leave room, or I'd advise anybody that's working with someone with moral injury or this type of pain or soul wound, to leave room for unresolved grief and allow that person to just kind of talk. And when they trust you, they'll allow you to hear their story. And in that way, we can be present to be wounded healers, come alongside that person and help that person, which is what I did in this veteran's case, get back on the bridge of hope. That person needed hope. And sometimes just being a pastorally present or being a non-judgmental presence can help that person get back to the place where they want to try again. And that's my presentation on moral injury today.
Thank you, Chaplain. I think that you provide a very clear example of why it's important to build between faith leaders and mental health professionals, because there's often overlap, and we should know what to do when it happens. So thank you for your time. So as we come to the end and wrapping up, like I mentioned in the beginning, this is just an overview. You know, we didn't want to spend too much time digging too far into what we do, because we want you all to consider these questions. So whether you are a faith leader or not, is there an official position statement regarding suicide from the leaders of your faith? And you can respond to any of these in the chat or in the Q&A, and we'll follow up with you. What are commonly held opinions of people of faith who attempt suicide or complete suicide? And this may look different from denominations, regionally, but in your experience, what are some of those common opinions? And so in your own faith group, is there a ministry or a group that works specifically with members who are experiencing mental health challenges? I know that in the church where I attend, we have what's called a Stevens ministry, and so it involves kind of providing mental health training to laypersons, not necessarily mental health professionals, but folks who are able to just sit and listen, as Chaplain Allen talked about before. And also, what attitudes or beliefs or structures within your faith group could help or present significant barriers when preventing suicide among congregants? And so, you know, we're talking about sort of the moral injury again, the guilt, the shame around having suicidal thoughts, or being even diagnosed with depression or with a mental health illness. You know, are there certain stigmas or barriers within your area of faith that might make it harder for someone to come to you, you know, to seek faith counseling? And so the chat and the Q&A is open for those. Also, in the left-hand corner is a little QR code. And that QR code, if you take a picture with your cell phone, you'll be able to complete a SurveyMonkey that gives us a chance to reach out to you when we have news, information, education around suicide prevention and wellness. It's a link to become a partner in suicide prevention. And so that's on this slide and the following slide for your information. But how do you weigh in? What are some of your thoughts? And I think I'm going to give it back over to Ms. True for her to moderate any questions that may come from the audience regarding these how do you weigh in kind of question prompts.
Okay, thank you, Tiffany and Chaplain Allen, for that awesome presentation. I learned so much today from you, and I am so appreciative and thankful for all of that information that you provided to me and to our audience. So now is the time for you, our audience, to ask any questions you have in the Q&A session to the right of our screen. I will repeat the question and Ms. Chambers will provide an answer. So if you have any questions, please ask them in the Q&A section below.
I see, Ms. True, someone mentioned that wives also need support. And that is a very good point. And thank you for sharing that. You know, one of the things that we often consider, and when I say veterans, I typically say veterans and their families, because no one veteran is walking through the door alone. And you're right, wives do need support. So in spending time kind of developing those partnerships, I know that a lot of the local mental health agencies are working, but we also want to help support whomever the wives and whoever the spouses are going to for support. So if the spouses are engaged in a current mental health provider, we want to make sure that they understand how to address mental health in the context of suicide prevention. So we're working with community providers to get them educated as well. So thank you for that.
Okay. Please ask any questions you may have in the Q&A box to the right of your screen.
So there was a question around a certificate of completion. I'm happy to do that. If you will put that or do the survey monkey, I'm happy to send a certificate of completion. I don't know if the Center for Faith and Opportunities is doing something similar, but I'm happy to do that on my end.
Okay. Thank you so much, Tiffany, for doing that. So as we're waiting for more questions, Tiffany, we're going to talk about the other helpful resources available.
So there are, I'm sorry, go ahead.
In the next slide. I think there was a helpful resources slide.
There is. So most of what I discussed in the presentation earlier, you'll see links for on this slide in terms of data, community toolboxes, sort of where we get our inspiration and support from will be here. Also, the last link is to Psych Armor. That has the full SAVE training. And so we did just a portion of SAVE today, but the Psych Armor link has the full SAVE training, which includes the video, and you'll also become registered to take any other courses on Psych Armor that might interest you. And so I would strongly encourage everyone to follow that link and look at the resources that are available there.
Okay, that is great. So what we will do now is I will say that if we did not get around to your question or you don't want to ask your question here, if you would please provide, your email will be provided after this, and we can get back to you with any concerns or questions or anything, issues you may like to address but don't want to address them here, just reach out to us and we will be glad to connect you to Miss Tiffany and Chaplain Allen. Um, there's a slide on right now with point of contact information for our office, and also there's another slide for point of contact information for Miss Tiffany and Chaplain Allen as well for the Durham, North Carolina community. So, Mr. Washington, would you like to say a few words at this time?
Thanks, True. Just a couple things. Thank you all for hanging in there. I see we dropped a few. This was a great presentation, Tiffany, as you always do. I appreciate your time. Chaplain, great information, great practical information that's applicable. You're on the front line providing pastoral care, and I love how you broke that down so people can understand that it's not just about giving information. Sometimes you just need to be quiet and listen, and I appreciate that because we all can be effective where we are. A couple of things for the audience, for those who called in. You're probably asking yourself, and I'm trying to think for you a little bit here, how can we connect with the Center of Faith or with Tiffany or whatever? So I have to give a plug for the VA's Pocket Guide. It was really our Pocket Guide that we created in our office. And the cool thing about the Pocket Guide is I got this vision that every faith-based organization, no matter what denomination it is, right, can have a veteran ministry, welcome center. It can be something small as coffee at Starbucks, fishing. The chaplain talked about people connecting as well. We want people to connect at your organization. And all we ask is that you have that ministry. It can be one person, 50 people, whatever. Just connect with us so that we can continue to feed you information so that we can accomplish two things. That's to connect you and that ministry to the VA resources and to connect you and that ministry to community services, right? Because it does take all of us to work. And we know that faith without works just does not work. And here we talked about the works. The works in this piece is having those resources that can help hand in hand with the faith. So we appreciate y'all joining us. If you have any further questions, I see Tiffany's information there, our information is up there. Thank you all for joining us. And as a note, we have another webinar next Wednesday, July 1st. And that's going to be with the Prevents team in Indiana, the Indiana audience, but you're welcome to log on with us. And again, that's regarding specific information on how to prevent suicide as well, but a different type of presentation. So we look forward to you all joining us in the future. Be blessed, and thank you all very much for joining us.
At this time, we adjourn today's meeting. Thank you.